Monica Peak. On behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's educational activity entitled A Call to Action for Health Equity, Racial Disparities in the Care of Patients with Cardiometabolic Disease. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's CME CE activity is also eligible for ABIM MOC points, so make sure you engage in today's events, answer polling questions, submit questions, and provide your feedback. Once you complete today's program, be sure to provide your ABM ID and birth date in the evaluation. CME Outfitters will submit your MOC points. You can also claim this activity as CME for MIPS improvement activity, so please make sure to participate and provide examples of how you will change your practice, and CMEO will send your confirmation of your participation, which you can submit to CMS. I also want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. We will be monitoring the Twitter feed and responding to your tweets as they come in. One last item I want to note is that we are using an enhanced platform today that allows you to save slides, take notes on slides, answer polling questions, and send us your questions. Please look at the tabs on the left of your screen and give us your feedback on the program and the platform as well. As I mentioned, I'm Dr. Monica Peak. I'm an associate professor of medicine at the University of Chicago, where I also serve as the associate director for the Chicago Center for Diabetes Translation Research. I'm the executive medical director for community health innovation, and I'm also the director of research and an associate director for the McLean Center of Clinical Medical Ethics. Let me start by first welcoming my colleague, Dr. Mark Cohen, who is the chairman of the Department of Medicine and former director of the Division of Cardiology at Newark Beth Israel Medical Center and a professor of medicine at Rutgers. Welcome, Dr. Cohen, and thank you for joining us today.
Thank you. I'm very excited and very flattered to join you, Dr. Peak.
Very excited to have you with us. Also with us is my colleague, Dr. Fatima Cody Stanford, an obesity medicine physician scientist and assistant professor of medicine at Harvard Medical School. Welcome, Dr. Stanford. So good to have you with us today.
Thank you so much, Dr. Peak. It's great to be here with you.
So let's get it started. This is such a vast topic, but we're going to touch today on several important points, including the epidemiological link to cardiometabolic health disparities in minority populations. Our first learning objective today is to identify the structural and social determinants of health that place African Americans, Latinos, and other minority populations at risk for poor outcomes in cardiovascular disease. So we're going to start by an audience response question. So for you in the audience, first, how do you consider social determinants of health when assessing patients with cardiovascular disease for minority populations? A, never. B, sometimes. C, often. And D, always. And I'll say that this is something that we as providers have only recently started thinking about. So I imagine there's probably going to be a range of responses. And so I'll be interested to see what we see come up in the response. Okay, so about half the people said sometimes, which is probably where I expected to see this fall. Dr. Stanford, what do you think about this?
Yeah, I think that this is exactly, what I would have thought, that you have this dispersion where you do have some people that are engaging in and really thinking about this work, but hopefully by the end of this program, we have, always, people thinking about this. So I think that'll be a great shift.
Excellent. So we'll begin starting to think about these social determinants of health. Structural racism being a major driver of that. So structural racism drives these social determinants of health that impact disparities across the board. Dr. Stanford, you've talked about how exposure to such stressors and social class itself affects health. What can you tell us about this?
So what we know is that when we look at the social determinants of health and susceptibility to disease, that there is a strong linkage. And this is part of why when we just did that polling question, we really wanted to have this somewhat integrated into our thinking always. And I really want to get into this idea of economic inequalities, racism leading to higher incidence of cardiovascular disease and other associated disease processes. But let's, look at racism and its link to health. And this is a very basic diagram that you see here, taken from a article that just came out that I helped co-author for the American Journal of Clinical Nutrition, where we look at racism and its link to health by looking at biologic, social, physiologic, and other health outcomes in their intertwined nature, not recognizing that these things are divorced from each other. These things are quite intertwined together. But let's look at this even deeper. Let's go a little bit further and look at racism and diabetes disparities. And I really, really enjoyed this slide by two of my favorite colleagues at Hopkins, because what this really shows you is racism and diabetes disparities. What you can see here in the center of the slide is we have racism leading to residential segregation, discrimination, and socioeconomic issues. When we look into that kind of column with residential segregation, we're looking at how being of lower socioeconomic status leads to issues like overcrowding, environmental toxins, low health literacy and education level and employment. In that middle column, depression, chronic stress, maladaptive behaviors, all being linked to cumulative biopsychosocial issues, low birth weight, obesity, which is my area, diabetes progression. And then kind of in this far white area, it's this socioeconomic deprivation issue leading to the uninsured or underinsured, limited healthcare access, lower diabetes prevention and treatment. All of these then culminating in disparities in diabetes-related complication and premature mortality, which we often see in communities of color here in the United States. But I want to hand this back to Dr. Pete to take us through some additional findings.
Thank you. One of the things that we have a lot of data about is racism in society in general and how that impacts health. What we're learning more and more about is how structural racism and interpersonal racism within the healthcare setting itself can also impact health. So as a diabetes researcher, one of the things that I study is specifically healthcare discrimination and how that may impact chronic health outcomes like diabetes. And so in some studies that I led, we were looking specifically at these kinds of associations. And we found that people who were reporting perceptions of discrimination within healthcare had worse diabetes care in several domains, including things like flu shots, diabetes-related primary care visits, and had twice the odds of having more diabetes complications, such as diabetes-related eye disease and foot disorders. And then in a separate qualitative study, we were looking at influences of perceptions of discrimination on interpersonal aspects of care, like shared decision-making. And we found that there are negative influences on that kind of care delivery as well. And there have been other studies that have showed that physician biases may affect treatment in minority children. We were looking at adults, with other studies that look at minority children with type 1 diabetes. And so even when there's equal access to care, there are disparate outcomes as well. So diabetes is just one chronic disease, but we know that there are multiple kinds of chronic diseases that have associations between discrimination and racism. And one of the studies that is a favorite of mine is the Black Women's Health Study. It's an important landmark research study that's been backed by over 20 years of data. It's important to me personally because I've been a participant in this study for decades, since I was a resident at Stanford. So Dr. Stanford, what can you tell us about this data and how it links to obesity?
Well, first of all, I'm just delighted that you have participated so that we can have this great data. My mom is also a participant, so a lot of my favorite people participants in this, what we consider to be the largest prospective study looking at Black women. Particularly what I want to look at is obesity, which is the largest chronic disease of our time. 42.4% of US adults have the disease of obesity, but it disproportionately impacts communities of color. The reason why I want to hone in on this is that in this particular study, we've over 59,000 individuals looking over 20 plus years. And what they did was ascertain whether or not these individuals, these Black women, or middle class and usually above, were experiencing either everyday racism or lifetime racism, and how this corresponded with obesity risk. What we do know is that racism is a stressor. Stressor leads to adipose tissue or fat tissue deposition, and this was increased in the cohort. What they found is that those that reported increased incidence of everyday and lifetime racism had much higher rates of obesity than those that did not. And so this shows that strong linkage between chronic disease and racism. They are not devoid of each other. But despite this, when we talk about obesity treatment access and the disproportionate impact that we see on communities of color, for example, if we want to hone in on Black women, the group that I belong to, we know that almost 60% of Black women have the disease of obesity. Another 20% have what's called pre-obesity or overweight, which means that 80% of Black women here in the United States fall within these categories. But why do we see differences in access as we look at racial and ethnic disparities? I think we need to point out a few things. First of all, there's biases, false assumptions, and knowledge gaps that create disparate cardiometabolic care here in the US and around the world. There's this link of obesity to willpower and just needing to eat less and exercise more, not taking into account other issues that are commonplace and leading to obesity, like medications that are weight promoting, lack of time, psychosocial stress, psychological stress, fatigue, genomic predisposition. These things are hugely important, particularly if we're looking at communities of color. And we're assuming that the patient is not intelligent and won't adhere to regimens without giving them their voice to express what's going on, which may have led to their excess weight. And we assume patients are not good candidates for weight loss therapies, which include medications and surgery. And then there's this lack of risk counseling and follow-up care that often happens. A lot of this is secondary to our inherent biases with regards to obesity as a disease, but particularly in communities of color. So let's look at obesity in the midst of this pandemic that we're in. I'm calling this, an intermediate phase or modified phase because the pandemic is not gone.
No.
And what we do know is that these high rates of obesity, particularly in Black and Hispanic women, I want you to see this is some data that is self-reported obesity. And so I want to really point this out. Self-reported obesity rates tend to underreport as opposed to NHANES or National Health and Nutrition Examination Survey data, where we actually have tangible things. But you can see here that there are differences even in the self-reported data. What I want you to also notice is that more than 25% of patients with obesity also have diabetes, and that diabetes raises cardiovascular disease risk factors 2 to even 4 times higher. Black and Hispanic populations do have the highest rates of diabetes and hypertension. But I want to point this out, particularly as we think about COVID-19, its dominance in our life, and what it really has done. And what we have found is that obesity is the #1 risk factor associated with morbidity or mortality with COVID-19. It triples the risk of hospitalization for COVID-19, and it decreases lung capacity, things of this sort. We've seen a quadrupling in the number of patients that are seeking care for their obesity in the midst of the COVID-19 pandemic. But, diet is, one of the more obvious direct factors for cardiovascular disease health, but we often blame the patient when it is also about a lack of access. So Dr. Cohen, do you want to take us through the data on social determinants of health, disparate cardiovascular disease access and outcomes?
I'd be happy to. And the ideas that we have emanate from very, very large studies that are providing a foundation for linking things like glycemic index and cardiovascular disease and death. It is well known that patients who are diabetic clearly have an increased incidence of cardiovascular disease, but even before becoming diabetic, a pattern of high glycemic index food intake, as is seen in many low income and moderate income groups, and as is seen in communities where fast food and inability to access higher quality foods in the local grocery stores or supermarkets definitely impacts those patients down the road. So in this particular analysis, 137 patients were followed. These patients were between 35 and 70 years of age. And they were followed for close to 10 years. And the high glycemic index foods were clearly associated with an excess of mortality compared to a more neutral glycemic index pattern of eating, and also cardiovascular events short of mortality like stroke, myocardial infarction, and rehospitalization. Keeping in mind that many millions of Americans are food insecure and are possibly going to be more gravitating towards a fast food diet or a glycemic diet or a diet that may be more affordable, that sets the stage for this correlation between a high glycemic index and very sinister impact on cardiovascular disease and death. The patients that are relying on food banks also, to a large extent, will end up aiming more for these high glycemic index type foods as well. And so they will a priori be at an increased risk for poorer outcomes. This relationship between glycemic index and cardiovascular death is accentuated in patients who already have diabetes and already have hypertension. So it's almost like a double whammy for many patients in low and middle income groups that are sort of on the fence with regard to their economic status.
Thank you both for this wonderful introduction to some of the causes of disparities in cardiometabolic care. And it really underlies the importance of addressing structural causes now and early for us to have improvements in cardiometabolic outcomes, particularly things like food insecurity, not only for obesity, but also diabetes and cardiovascular disease. And thinking about how we can work more effectively around the poverty that drives food insecurity, as well as collaboratively with organizations like food banks. So we're going to move on to our second learning objective, which is to recognize the impact of bias and health inequity on outcomes of patients with cardiometabolic disorders. So from the data, we know that African Americans are 1.3 times more likely to have obesity compared to non-Hispanic white populations. So Dr. Stanford, what can you tell us about this increased burden of risk?
Absolutely. Thank you so much, Dr. Peak. I really want to point this out because obesity is often the disease that we don't address. We weren't educated about it. And I really want to talk about its impact on really everything else. So let's look at obesity, which we see here in this slide. And we see its impact on dyslipidemia, hypertension, pre-diabetic states, non-alcoholic fatty liver disease, polycystic ovarian syndrome. But we see outside of this circle where we're looking at cardiovascular and cardiometabolic disease, a host of other diseases, mental health issues like depression, cancer. We know of 13 cancers that are associated or caused by obesity, gallbladder disease, osteoarthritis, sleep apnea, dismotility, and disability. All of these, are associated with an increased risk and burden, which we said is much more pronounced within communities of color. Now, why is this? What is this about obesity? How are we looking at it as a disease? Let me explain how the brain actually regulates food intake. So we're going to take the brain and slice it down the middle. We get to a middle section of the brain in this cross section called the hypothalamus. Now, the hypothalamus is getting signals from different parts of our body to tell us not only how much to eat, it also tells us how much to store. So we're getting signals from our fat tissue, leptin in our fat tissue, cholecystokinin in our small intestine, peptide YY in our large intestine, insulin in our pancreas, ghrelin in our stomach, all sending signals back via the spinal and vagus nerve to tell us how much to eat and how much to store. Now, let's look at this a little bit deeper because you're going to learn some obesity pathophysiology, and let's look at the signaling pathways. I'm going to make sure you know this before we leave. There are two primary pathways by which the body travels, and we're going to focus on leptin, which is signaling from adipocytes, or what we consider to be fat cells. We're going to focus on the bottom portion of this diagram. When leptin binds to this receptor, it stimulates a neuron in the brain called the POMC, or the pro-opiomelanocortin neuron, here in the arcuate nucleus of the hypothalamus. When we travel down that pathway, alpha melanocyte stimulating hormones then bind to the melanocortin 4 receptors and stimulate the production of something called BDNF, which stands for brain-derived neurotrophic factor. Persons that travel down that pathway receive an anorexigenic signal, which means they not only eat less, they store less. As I exclusively care for patients with overweight and obesity between the ages of 2 and 90 as an internist and a pediatrician, my patients signal down an alternate pathway, where leptin binds to a different receptor and stimulates a different neuron in the brain called the AGRP neuron, or the agouti-related peptide neuron in the paraventricular nucleus. We signal down this pathway. Instead, the AGRPs bind to the melanocortin-4 receptors and inhibit the formation of brain-derived neurotrophic factors. Those that have low levels of brain-derived neurotrophic factor receive an orexigenic signal, which tells them not only to eat more, it tells their body to store more of what they eat. Now you may be like, Dr. Stanford, what does this have to do with the social determinants of health? Oh, don't worry, I'm going to bring that home in the next slide. What we will see here is that there was a large study done of over 30,000 individuals. And in this particular study, they sought to hone in on who signals which way. Are there differences by race and ethnicity? And I want you to see here that we're going back to that BDNF. I want to remind you, high levels of brain-derived neurotrophic factor, leaner phenotype, like you see on the left side of this slide. When you have obesity, lower levels of BDNF on the right side of the slide. Now, interestingly enough, those that were of African descent and Hispanic descent out of that 30,000 individuals were more likely to have that CC allele pairing and more likely to have obesity than more non-Hispanic white populations where they had a TT allele pairing and had a higher likelihood of having higher BDNF levels. Now, this is something that people are unaware of. Now, I don't think this is the complete cause of the disparities we see in obesity, but one such explanation for why we see disparate values when we're comparing majority populations to those that are not. And so this is extremely important. Let's look a little bit at this a little bit more. Dr. Peak?
So one of the things that I'd like to do is discuss your specific research a little bit more and talk about some of the access issues around obesity diagnosis and treatment with weight loss and bariatric surgery. So as we pivot, and thank you so much for sort of making sure that we're all level set about some of the pathophysiology that disproportionately affects minority populations to put us at increased risk for obesity. Can you also talk about some of the other factors that are relevant?
Absolutely, Dr. Peak. It's my absolute delight to do so. So when we talk about access issues, we've already talked about the higher burden of obesity within communities of color, but what does that mean in terms of access? We know that bariatric surgery is by far the gold standard treatment for those that have severe obesity or moderate obesity with one of the obesity-related diseases, which includes type 2 diabetes, obstructive sleep apnea, or heart disease. But what happens? Who's getting referred to surgery? So I studied this in a particular study that came out back in 2015 to ascertain here in 2 of our academic centers in the Boston area, who's likely to proceed with surgery? Does this vary? And what we found was that racial and ethnic minorities were just as likely to proceed with surgery if referred than white patients. The comorbid illness burden was similar. Baseline BMI was higher, but what we're finding is that Black and Hispanic and Indigenous people are not getting diagnosed with obesity at the same frequency, despite the significantly higher prevalence. Now, when we look at Roux-en-Y gastric bypass, which is now the second most common form of surgery performed for metabolic and bariatric surgery, this is a study that really shows you the status of affairs back in 2014 when Roux-en-Y was king in terms of being the most frequently performed surgery before the vertical sleeve gastrectomy. What I wanted to show you here is that we've talked about this disproportionate burden on communities of color, but you can see here in this over 108,000 individuals that got surgery that there's a much lower likelihood for racial and ethnic minorities to get surgery, despite the prevalence or preponderance of us in the population. You can see that there's differences when we're looking at Black patients in terms of issues surrounding BMI, more likely to have hypertension. And when we're looking at serious adverse events, you can also see that there's variation by race in this large cohort of individuals that got Roux-en-Y gastric bypass. Now, when we look at response to treatments like surgery or pharmacotherapy, people have posited that there's differences in response, and these differences in responses may be associated with things such as demographics or clinical features like body mass index being higher, a higher illness burden with regards to comorbidities, quality of life issues, or maybe it's behavioral in nature. Maybe there's differences in eating behaviors, physical activity, alcohol intake that lead to these disparate outcomes. And these may be things that we should consider when we're thinking about individuals that are going to trying to get access. What are some of the things that may create a differential response? And so, that's extremely important. But, I want to move forward back to Dr. Peak to take us through some additional things.
Well, we have two questions that have come up really quickly. One is specific to this slide, and it asks, are there differences in keeping off the weight after surgery?
No, actually, they're not. That's a really good question. That's one of my favorite topics. We didn't present any of my research on that, but that's like my gold standard. We see that about 25 to 35% of patients who've undergone metabolic and bariatric surgery will have a pretty significant degree of weight regain or either inadequate weight loss. We do not see any significant differences by race or ethnicity. Now, I say that, and I'm going to put a little star in that and say that on average, if we're looking at, for example, non-Hispanic Black individuals, that if we're looking at response to surgery, that there's a lesser loss on average, about 8% difference when comparing non-Hispanic Black individuals to non-Hispanic white individuals. So there's a little difference in the response overall. However, I think that varies. And if you see study after study, you see some that show no variation. And a lot of it ends up being dependent upon the follow-up care and whether or not pharmacotherapy, meaning anti-obesity pharmacotherapy agents, are introduced at the time of NATE or post-surgery or not.
Excellent. Thank you. There was another question that came in, asked me specifically, are there one or two questions we can ask patients that address the social determinants of health in a culturally sensitive way in a limited time visit? And so I'll just make a comment there that the most commonly screened for thing that we're doing now in healthcare systems is for food insecurity because of its such close association with chronic diseases like we've just mentioned. And there's a 2-item instrument that had been validated in pediatric populations. And then some of my colleagues here at the University of Chicago, Dr. Stacy Testor-Lindau, Jennifer McCloskey, and others have validated that for use in adult populations in healthcare settings. And so you can Google hunger vital signs. It's a 2-item instrument that has now been validated in urban African-American adult populations and many other settings.
I want to just chime in there. We actually recently passed here in Massachusetts at the Massachusetts Medical Society for that to be included with any assessment here done in Massachusetts. So I would like to echo and support exactly what you've stated, Dr. Peak, that this is something that's extremely important, very useful, and it only takes about 30 seconds away from your clinical visit.
Thanks so much. One last question before we move on. Do patients of color also have higher rates of cardiovascular disease and myocardial infarction linked to specifically obesity?
Absolutely. Unfortunately, yes, we do see much higher rates of heart disease and cardiometabolic disease associated with obesity due to the higher burden. We do think it accounts for a significant reduction in the life expectancy that you particularly see in a very pronounced way in Black communities, for example, here in the US. And so absolutely.
Great. Dr. Fatima, what can you tell us about the high incidence of diabetes and patient outcomes in other minority populations? What are we seeing from the data? We've talked a lot about African Americans, but what do we see in other kinds of minority communities?
Absolutely. I think that's a great question. What we do know, I'm going to focus on 2 different groups. Within the Hispanic population, we see differences. I want to show this slide here. Look at this. 20.6% of Native Hawaiians and Pacific Islanders have this issue with diabetes. We see 18.7% of African Americans. You guys have already heard me talk a lot about that. Let's look at the Hispanic and Latinx population, 11.8%, and let's contrast that to what we see in white Americans. When we're looking at morbidity, kidney failure 3.5 times higher in the Native American population. Diabetic retinopathy much higher within the African-American population, and along with diabetic complications where we see blindness, both below and above the knee, amputations, kidney disease, heart attack, and stroke. So going back to the question that Dr. Peak asked earlier from the audience, when we talk about mortality, this is really the sad piece of the puzzle. Even more so is that Native Hawaiians, 22% higher rates of mortality when we're comparing to non-Hispanic white populations. African Americans, 2.3 times more likely to die from disparate income issues with diabetes. And then Hispanic Americans, 1.5 times more likely. So I think you can see that if we look at our major racial and ethnic groups, that we see, unfortunately, higher morbidity and mortality within these groups as it relates to diabetes, as it relates to obesity. And I think that's extremely important.
Absolutely. Thank you so much. We're going to start shift a little bit and start talking about some more areas of prevention. And we have a couple of questions coming in that are related to that. Dr. Cohen, the poor outcomes in cardiovascular health that we see in many minority populations are the result of disparities in cardiometabolic disease prevention as well as care. And so what are you seeing in your patients in the data?
The first thing is that we need to respect the fact that all of these disparities and all these inequities have a very, very unfortunate, sinister impact. And the impact is straightforward. If you look at the numbers on this slide, it's a little bit shocking. Close to 50%, 47% of Black patients will experience CVD sometime in their lifetime, and that number is expected to go up to an even 50%. We all know, and this is now established pretty clearly in many of the epidemiologic assessments and analyses, that there is a lifespan disparity between Black Americans and white Americans. In other words, Black Americans have a significantly shorter life expectancy. We can attribute 1/3 of that decreased life expectancy to cardiovascular disease. And as by now the audience should be sensing, things like diabetes, things like poor quality food intake, the glycemic index, things like diabetes and obesity together, hypertension, all of these things gang up on the minority populations and especially the Black Americans to reduce their life expectancy. And the mechanism of that reduction very often has to do with a cardiovascular event. Specifically, African Americans are 2 to 3 times as likely as white Americans to actually suffer a fatal cardiovascular event. And one of the unfortunate statistics in Native Americans and other minority population is that they experience a much higher mortality rate from CVD at a younger age. So in fact, 36% of Native American Indians under the age of 65, compared with 17% in the overall American population, die at a younger age. And that's very unfortunate. If we look specifically at one of the cardiovascular diseases, which is very common and a very big burden on health care, per se, in the United States, is heart failure. And if we look at heart failure in relation to race, we see these different colored lines identify very, very clearly a disparity between Black men and women relative to white men and women. And we can also look at age differences. So on the far left, you actually see racial disparities in mortality in the younger age group between 35 and 64 years of age, where Black men experience the highest rate of heart failure related cardiovascular death. The differences are not quite as extreme in older patients, but still Black males and slightly less so Black females still have higher rates of heart failure related mortality in the older age group. So this disparity is pretty well established. If you proceed to look at some of the disparities in access.
Dr. Cohen, I'm going to just one second, because we have a few questions coming in.
Sure.
When you had showed us the slide about Native Americans, there is a question about whether or not those rates were similar in Alaska Natives. And I know that a lot of times some of the problems with the data we have is that there's a lot of clumping of data, and we can't sort of parse out some of the differences we see in subpopulations. But do we know if the rates are similar for Alaska Natives?
Yeah, I can't say that the numbers are similar, but I can tell you that in a generic way, Alaskan Natives population is usually subsumed within the Native American population, but I can't say exactly what fraction of information comes from that specific subgroup. But in general terms, those patients behave in quite similar ways as an average, quote unquote, Native American population.
Great. I'm going to ask one more question because two came in that are similar. I know we're going to get to strategies, but just as a big picture idea, as you're talking a lot about disparities in cardiovascular risk and disease so early in life, does this mean that we should be more aggressive for racial and ethnic minorities earlier to try and prevent disparities later in life for cardiovascular morbidity and mortality?
Well, the impact of racism takes its toll in patients at a younger age, and therefore the person asking the question is absolutely correct. And later on, I will emphasize this as a core feature of my interest here, and that is to try to start early. As I'm sure Fatima Cody Stanford will agree, that a lot of the things she sees relating to obesity start at a young age, and therefore our biggest hope is to try to get into the younger age group and either change patterns or have more impact and try to really take down some of the structural barriers to the reaching younger people and helping them get directed towards a healthier lifestyle in order to avoid what will inevitably happen, which is to have a premature mortality.
Great, thank you.
So we do want to highlight major differences in cardiovascular care access, which have been studied very, very well. You'll see that many of these studies are not even that current. That is to say, these differences have been clear to us, those of us who read the published scientific literature,